We will cover an overview of smoking cessation to give you a frame of reference for some of the key ingredients that go along with this. My references are listed there. What we'll cover today is 10 findings from the U.S. Department of Health and Human Services. We'll talk about the effects of smoking, determining the severity of a smoker, know the variety of nicotine replacement therapy options, or NRT, discuss motivational interviewing, referred to as MI, and talk about the 5 A's, and that should be 5 R's, not percent R's. In 2008, there was an update provided on treating tobacco use and dependence from the U.S. Department of Health and Human Services. And this really was a conglomeration of information from 8 federal agencies, and they've done this 3 times, the first time starting in 1996. And they look at about 3,000 published articles each time they review this to find out really what are the key things that we know about smoking and distill it down into these 10 key guidelines. So the first one is effective treatment exists that can significantly increase the rates of long-term abstinence from smoking. Number 2, it is essential that clinicians and healthcare delivery systems consistently identify and document tobacco use status and treat every tobacco user in a healthcare setting. Number 3, tobacco dependence treatments are effective across a broad range of populations, and that quitting should be encouraged in every patient willing, and to use the counseling treatments and medications recommended. The 4th recommendation is that brief tobacco-dependent treatment is effective, so clinicians should offer every patient who uses tobacco at least brief treatments shown to be effective. Number 5, individual, group, and telephone counseling are effective, and their effectiveness increases with treatment intensity. So those things like Idaho has the Idaho Quit Line, those telephone counseling services have been proven from the research to be effective. 2 components of this counseling are especially effective, and clinicians should use them when counseling patients to quit. So both practical counseling, meaning problem-solving skills and training, and the social support aspect delivered to patients as part of the treatment. There are numerous effective medications that are available for tobacco dependence. And the list of those is there. 5 of those being nicotine replacements, the other 2 being oral medications. Number 7, counseling and medication are effective when used by themselves for treating tobacco. However, the combination of counseling and medication is more effective than either one is alone. And so clinicians should definitely encourage the use of both. Again, this telephone quit line counseling is able to reach a diverse population and has a broad reach. Therefore, clinicians and healthcare delivery systems should encourage the use of this. If a tobacco user is currently unwilling to quit or to make an attempt, clinicians should use motivational treatments shown to be effective. And number 10, tobacco dependence treatments are both clinically effective and highly cost-effective related to interventions for other clinical disorders. So again, these 10 things are important to remember just as kind of the truths of smoking cessation. And by no means am I an expert in smoking cessation. I find this interesting and not necessarily that I believed all 10 of these things before reading this, but I do think these are the things we need to keep in the back of our mind, or are the things that have been proven for tobacco cessation. So what do we know about the effect of nicotine on the human body? It really varies and it affects the entire body. So let's talk about the cardiopulmonary involvement. Smoking is a major independent risk factor for coronary heart disease, cerebrovascular disease, and with nicotine being one of the most biologically active chemicals in tobacco and smokeless tobacco. Immediate cardiac consequences of nicotine include acute increase in heart rate up to 10 to 15 beats per minute, and an increase in blood pressure of up to 5 to 10 millimeters of mercury. Inhaled nicotine causes a dependent cough and airway obstruction due to stimulation of the nerve endings in that bronchial mucosa. So we definitely see this complaints in smokers of shortness of breath and tight chest. What about psychoactive involvement? It's important to remember that nicotine is a major psychoactive ingredient in tobacco smoke. It releases a neurotransmitter such as dopamine and serotonin. These central nervous system changes include an increased memory, concentration, and alertness. It reduces pain and anxiety and increased sensitivity to brain reward systems. The majority of withdrawal symptoms experienced with tobacco cessation are attributed to nicotine, that anxiety, irritability, restlessness, cravings, and increased appetite. Replacement with nicotine replacement therapy and slow weaning are helpful at reducing these symptoms. What about effect on weight on appetite? Smokers tend to weigh less than non-smokers, and smoking cessation often leads to weight increase. This relationship can partially be explained by the effect of nicotine on appetite suppression and increased metabolism. What about other effects? Nicotine is a potential cause of cancer. It decreases wound healing. It amplifies skin aging. It increases platelet adhesiveness. Smoking during pregnancy has been associated with spontaneous abortion, placenta previa, placenta abruption, preterm birth, stillbirth, fetal growth retardation, low birth weight, and sudden infant death syndrome. So there is a lot of danger to smoking when pregnant. What about tobacco products? The cigarette is considered a drug delivery system. There's over 6,000 chemicals in cigarette smoke, 79 of which are known carcinogens. What about methanol? Menthol. Sorry, I started to say that wrong. And it's because it's typed wrong on there. I'm sorry. I will fix that slide before I post it for you. There are several different brands, flavors, and types of cigarettes available. It's important to the addition of menthol flavor to a cigarette contributes to a numbing and cooling effect in the throat that encourages smokers to take a longer drag or inhalation, thereby inhaling a larger dose of nicotine and tar. Due to the anesthetic properties of menthol, smokers might report a lower pack-year smoking history, so they might not say they've smoked as much, which I thought was interesting. I didn't know that about menthol cigarettes. What about light cigarettes? These have been misleading to the public as they are perceived as being safer. What the light and ultralight products have done is the manufacturers manipulate the ventilation holes in the filter of the cigarette, allowing the them to dilute or decrease the tar levels in these products. However, that doesn't reflect how the smoker might actually use the product. A smoker may cover these ventilation holes or alter their smoking pattern. What about cigars? Cigars are not meant to be inhaled. So as a result, it's misperceived as a healthier alternative to cigarettes. However, cigar smoke contains toxic and cancer-causing chemicals that are harmful to both the smoker and non-smokers. It's found that some chemicals are actually higher in cigar smoke. And this is interesting. Even if a person does not inhale cigars, they contain higher rates of carcinogens that affect the lips, mouth, tongue, throat, and larynx. Additionally, when saliva containing the chemicals in tobacco is swallowed, the esophagus is also exposed. We're hearing more and more about electronic cigarettes. They are those pre-filled, refillable cartridges that vaporize a liquid, and puffing on the device activates a battery-operating heating element to produce a vapor that is inhaled. Electronic cigarettes are promoted as an alternative to smoking and as a way to reduce the amount of burnt cigarettes. And that can be a benefit if people are really trying to quit. Excuse me. The difficulty with electronic cigarettes is it really has opened up a new venue for younger smokers to start using tobacco, which is proving to be a problem. And there are small studies coming out that are showing lung illness and disease from the use of electronic cigarettes. What about hookahs? Hookah is a smoking that's believed to have originated from India, and it's been part of some cultures for centuries. The pipe is called a shisha, and it's a mixture of tobacco and sweeteners and fruit flavorings. Individuals have been studied that smoke a hookah on a regular basis, and there does seem to be an addictive nature to the tobacco, and people have developed chronic lung disease from using the hookah. Another interesting thing about hookahs is, unlike cigarettes, hookah pipes are commonly shared by multiple people in a social setting. The sharing of a common mouthpiece is a breeding ground for bacteria and infectious disease transmission, such as herpes, tuberculosis, influenza, and other infectious disease. Exacerbating this problem is a lack of regulation on hookah pipe cleaning at hookah bars and lounges. So there's some food for thought. What about smokeless tobacco? The health consequences related to the use of it include oral and pancreatic cancer, receding of the gum line, and periodontal bone loss are the main criteria. So let's talk a little bit about the neurochemistry of addiction. It's a primary chronic disease of the brain. There's this reward, motivation, memory that's part of this. And it's important to remember the initial use of substance is typically voluntary, but over time the brain chemistry changes and the person's ability to resist impulses to discontinue the use of the substance is reduced. And it's also important to note that the chronic nature of drug addiction is similar to that of chronic disease. Drug addiction can be managed successfully, however, it is common for a person to relapse. Sorry about that. It's important to remember that the chain of addiction is multifaceted and is influenced by both physical, social, and mental factors, and that prevention policies should address all three of these issues. So there is something called the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, and that's the 5th version that came out in 2013. It's a standard classification of mental disorders used by healthcare providers and includes the diagnostic criteria. And this is how nicotine dependence is classified by these 10 different areas. So the first one is the individual may take the substance in larger amounts over longer period of time than was originally intended. The second criteria is the individual may express a persistent desire to cut down or regulate substance use and may report multiple unsuccessful efforts to decrease or discontinue use. The third criteria, the individual may spend a great deal of time obtaining the substance use or substance or recovering from its effects. 4, craving is manifested by an intense desire or urge for the drug that may occur at any time, but is more likely when in an environment where the substance was previously obtained or used. Number 5, recurrent substance use may be the result of failure or fulfillment of major obligations at work, school, or home. Number 6, the individual may continue substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effect of the substance. Number 7, important social, occupational, or recreational activities may be given up or reduced because of the substance use. The individual continues to use the substance or in situations that could be physically hazardous. Number 9, the individual fails to abstain from use despite the knowledge of physical or psychological problems caused or exacerbated by the use of the substance. And the last one, the individual develops tolerance to the substance, which results in the individual seeking more of the substance to produce a desired effect. There is a number 11, sorry that's not on there. The individual experiences withdrawal, which is a physical condition that occurs when the blood or tissue concentrations of the substance decline in an individual who has maintained prolonged heavy use of the substance. So what they do is they look at these 11 criteria and then they develop a severity. So here's the severity. If somebody has 0 to 1 of them, there's no diagnosis of the severity of the classification of tobacco dependence. 2 or 3 is a mild substance use disorder. 4 to 5 is a moderate substance use disorder, and greater than 6 is severe substance use disorder. So that's how we classify nicotine addiction. So how do we start the conversation? There's been these 2 methods proposed. The first one is the 5 A's, which is shown here in this description, which is to ask if one currently uses tobacco. And you can see if they say yes, then they go to advise to quit, assess their willingness to quit, and then assist them in their attempts. And the last A is arrange for follow-up. And if they say no, we still ask if they've used it before. And if they say yes, then we assess how it went and assist as needed. Then what happens with the 5 R's are the 5 R's go into this idea of relevance, is making this, the best advice is relevant to the patient's concern. So we make sure that it's age appropriate. We know about their prior quitting experience and something about their barriers to cessation at this time. Risks. When advising tobacco dependence patients to quit, focus on the risks that are important to them. Rewards. Emphasize the rewards to quitting smoking tobacco, such as improved health, saving money, better tasting food. Roadblocks. The patient's readiness to quit is often entangled with perceived roadblocks, which might include weight gain, fear of failure, the symptoms of withdrawal. Sorry, I'm recovering from my cold. The last one is repetition. It's important to promote effective outcomes through repetition. So what about motivational interviewing? That falls into those 5 A's and the 5 R's. But motivational interviewing is an evidence-based approach to address change designed to help people resolve their uncertainty about making meaningful personal change. The first part is this idea of there's stages of change that you've heard about before, but that pre-contemplation, where they're not considering any change or they're in denial. Contemplation, they're kind of ambivalent about it because they like what they're doing. Preparation, they are preparing to make a specific change. They might be gathering information or looking at ways of doing this. Action, even though many failed attempts have maybe happened, it's evident that action is often not enough, but there is something that's being done when you're in the action stage. Maintenance and relapse prevention involve incorporating this new behavior over the long haul. And so how does this motivational interviewing work? The keys are to express empathy with open-ended question and reflective listening. The idea is to roll with any resistance by avoiding direct confrontation and redirecting with questions that are focused on kind of what if, or really this idea that we're going to guide them towards something, not tell them what to do. We also develop some sort of discrepancy between a person's goals and their current behavior, and support self-efficacy by offering incremental steps that might bridge what seems like these huge obstacles. Here are a couple videos on motivational interviewing if you're interested in learning more about this. I really think it is a guided questioning, really to help the person bring out what they know and guide them towards better behaviors. So the way this works is you set an agenda and saying, is now an okay time to talk about your smoking. Collaborate with the patient, meaning we really want to know what their experience is. And it's asking them about their experience. And these are really where that open-ended questioning comes in, where we're not trying to lead them or tell them, but really get an understanding of what's going on with them. Examine the importance, determine importance and confidence, meaning how important is this change to the person and how confident are they about making the changes. So the questions that we might ask would be, what do you like about the effects of tobacco, and kind of summarizing these positive effects, and then ask something about the undesirable effects of tobacco by saying, what's the downside of tobacco use? What are some of the things you're going to miss? And we kind of summarize these negative aspects. And then ask them how ready they are to change based on those different positives and negatives. Anything that the patient says where they're talking about changing, make sure that we reinforce that and build upon it. And the last one is help to develop an action plan with the person for how they're going to quit. So here again is the list of tobacco treatment options. Again, focused on nicotine replacement therapy, since nicotine is the main ingredient in tobacco that causes addiction, and that nicotine is the main thing that has the withdrawal effects, and so replacement reduces those. What's interesting is there's evidence that combining the transdermal nicotine patch with one or more of the other short-acting nicotine replacement therapies is more effective than one strategy alone. There is information to know about each of these different nicotine replacement therapies. For instance, with the nicotine gum, it's recommended that the correct use of the gum is something called, quote, chew and park, end quote. The user would chew the gum until there's a peppery flavor that emerges, and then park it between the cheek and the gum to let the nicotine absorb. Bupropion is an effective option in the treatment of tobacco dependent. It works by blocking the reuptake of dopamine and norepinephrine, and it's shown to increase quit rates and decrease nicotine withdrawal symptoms and craving. The medication on the bottom of the list you've seen advertised probably. That's the Chavex, and it's also used as an aid in smoking cessation, and that is associated with the addictive properties of nicotine, and it's also been shown to reduce the symptoms of nicotine withdrawal as well as block some of the reinforcing or rewarding effects of smoking. So what about people with maybe that have had myocardial infarctions or cardiac issues? Providing tobacco dependence for patients with underlying cardiac conditions who have recently experienced a cardiac event can be a bit challenging, as they may be in critical areas. However, these need to be addressed, and there's evidence that nicotine replacement is appropriate in this particular group. Pregnant smokers, again, the earlier a pregnant woman stops, the better. Cigarette smoking during pregnancy has been denoted as the greatest modifiable risk factor for pregnancy related morbidity and mortality in the United States. It is unclear, however, if there's no evidence whether or not nicotine replacement therapy is safe to be done during pregnancy. Hospitalized tobacco smokers, the key thing for them is to remember that tobacco use in the United States is responsible for immeasurable suffering, nearly 500,000 deaths a year, and the healthcare costs estimated at $193 billion annually. For hospitals, hospitals are all non-smoking. So what we focus on here with patients is that the majority of their withdrawal symptoms they've already gone through during their hospitalization, and so it is a good time to quit. Some interesting stuff that I didn't know about second and third hand smoke is, I have known that second and third hand smoke is bad, and there are no safe level of cigarette smoke. What's interesting about third hand smoke is that contaminants from that can linger for hours. There are many contaminants that linger, but third-hand smoke is the residue left from second-hand smoke and may be left on the surfaces on various objects. Over time, third-hand smoke ages and becomes increasingly more toxic, leading to nicotine exposure levels that are similar to what a smoker experiences. That was the part I didn't know, is that it becomes more concentrated on surfaces. Okay, what about teens and preteens? A quick comment on that. That in general, smoking habits are established during adolescent years. More than 75% of adult smokers begin smoking before the age of 18. A few interesting things. There's been an increase in smokeless tobacco in white high school males and an increase in cigar smoking in black high school females. It's estimated that 4,000 to 6,000 children under the age of 18 start smoking their first cigarettes in the United States every day. And there are 1,000 teens and preteens that become daily cigarette smokers. 1 in 4 U.S. high school seniors is a current smoker. So that's where we are with those numbers. So system-wide implementation of policy development. This is why I think this is a good interprofessional exercise, is because public health impacts the use of tobacco. The other place this comes in is obviously that health of patients. It's part of our electronic medical record in that it's documented on each person whether or not they are a smoker, also documented whether or not we ask them to quit smoking. There's also a commitment to community-wide wellness as far as what our community is doing to look at smoking cessation. What about cost? Hospital reimbursement for smoking and tobacco cessation is reimbursed. It varies, but it has improved. Medicare provides coverage for both counseling and prescription medications, and in most states, Medicaid programs cover some, but usually not both therapies. So our wrap-up is those 10 findings that we say that we just have to know are the facts of smoking. I covered a brief section on the effects of smoking. We talked about how we identify the severity of smoker, a little bit on the various nicotine replacement therapies, and I discussed motivational interviewing. This should be our stepping off point for a general overall information about smoking cessation, so you know a little bit more. Now what you're going to do is go out and find information from your individual organization at a national and state and local level and see what else you can find out about smoking cessation.